here at Johns Hopkins School of Public Health in the Population, Family, and Reproductive Health Department. We are delighted to highlight three of our master's students today, Sydney Roth, Dr. Landon Krantz, and Dr. Sharmada Subramanian. And so we'll go ahead and start with Sydney. Sydney is in our MSPH program focusing on women's sexual and reproductive health. And she comes to us with a Bachelor of Arts degree in public health from Agnes Scott College. And the title of her presentation today is Better for All the World, Understanding the Present and Historical Reproductive Subjugation of Disabled Americans Through Forced Sterilization and Imagining a Better Reproductive Future for All.
All right. Hello, everyone. Thank you for the introduction. As stated, that is my presentation title. It's a little wordy, so I'm not going to repeat it. So my reader for my master's essay was Dr. Sharmada Subramanian, who introduced me. So during our time today, I will discuss the magnitude of the problem, the historical context, causes and determinants. I'll go over state and federal laws, and lastly, I will discuss policy recommendations. So before we go further, I want to talk about why I did my master's essay on this topic. So as a disabled person, I was appalled when I found out that it was legal for disabled people to be involuntarily sterilized, and I wanted to explore this issue and see what could be done to prevent it. So to start, I would like to frame this presentation with three key definitions. So forced sterilization is the involuntary removal of somebody's ability to reproduce, and coerced sterilization would be involving coercive tactics such as intimidation, misinformation, and incentives. And also disability. So disability has many different definitions, ranging from medical definitions to legal definitions to somebody's own definition of what disability means to them. So the CDC does define disability as any condition of the body or mind that makes it more difficult for the person with the condition to do certain activities and interact with the world around them. So it is legal for disabled people to be sterilized without consent in a majority of US states. In addition to sterilization, disabled people often face the loss of the reproductive autonomy. There are many ways people can lose the reproductive autonomy besides sterilization. So that could look like being forced to get an IUD or another form of birth control, being coerced into or against an abortion, not being provided certain services due to stigma or bias. So next I'll talk about the magnitude of forced sterilization. Historically, an estimated 70,000 people were sterilized under eugenic laws between around 1900 and the 1970s. Also, there's no current data on forced sterilizations. However, 6.2% of women ages 15 to 44 with disabilities have had a hysterectomy versus 2.2% of those without disabilities. And approximately 30% of women ages 15 to 44 with disabilities have been sterilized compared to 18.8% of those without a disability. So we must ask ourselves why. Why are their rates so much higher? Are there any reasons? Unfortunately, we do not have data on coerced or forced sterilization. So as of right now, we must use this data as a proxy to understand the sterilization landscape. So forced sterilizations emerged in the early 1900s with the rise in the eugenics movement. So in the US, eugenic ideology is centered around white, non-disabled, and wealthy people were seen as genetically superior. So a core tenet of eugenics is that disability and other undesirable traits are inherited. Some of the terms that were used to describe people that eugenicists wanted to stop having children were feeble-minded, incompetent, criminal, dependent, promiscuous, and socially inadequate. As a result, disabled women, poor women, Native Americans, and people of color were disproportionately targeted. So there was a Supreme Court case in 1927, Buck v. Bell. So this case gave states the right to sterilize people with disabilities or those perceived to be disabled without their consent. So Carrie Buck was deemed feeble-minded after she became pregnant via rape when she was 17. So her mother was actually institutionalized at the same institution before Carrie was, and that was used to support the idea that feeble-mindedness was inherited. And additionally, Carrie's baby was deemed feeble-minded when she was an infant. And so Carrie was actually an average student when she was in school and was not feeble-minded. However, this fact was not brought up during the case. So the Supreme Court decision, Justice Oliver Wendell Holmes wrote it, and he wrote that it is better for all the world if instead of waiting to execute degenerate offspring for crime or to let them starve for their imbecility, society can prevent those who are manifestly unfit from continuing their kind. And he also wrote that 3 generations of imbeciles are enough, speaking of Carrie's family with the 3. So in addition to eugenic sterilization in the earlier parts of the 1900s, there were also non-institutional forced sterilizations, and these used federal healthcare funding. So one example is the Relf sisters in 1973. 2 of the Relf sisters, who were from an African-American low-income family, were sterilized without their parents' consent at ages 12 and 14. The Relf family was targeted after receiving government assistance. Their lawsuit uncovered a pattern of over 100,000 sterilizations in federal family planning clinics annually, and many of them were estimated or likely to be coerced under the threat of government benefits being taken away. So on this side, you can see causes and determinants. I will only highlight a few because there's a lot. So due to disabled people's susceptibility to sexual abuse, parents and guardians might be worried about unattended pregnancy and they want to prevent that. However, sterilization does not prevent or protect against sexual abuse, and it does not excuse those from providing protection against sexual abuse. And also, present day forced sterilizations tend to occur in people who are under conservatorship or guardianship. And this is when the court gives somebody the legal power to make decisions for a disabled person. And lastly, disabled women and girls may be unable to manage their periods and therefore place what some consider an unnecessary burden on the people who care for them. So, turning to the federal laws and policies, Buck v. Bell has never been overturned. The Supreme Court says that they follow stare decisis, which means following prior decisions, and they do not overturn precedent often. But due to the makeup of the Supreme Court, going through the Supreme Court is not really an option. So onto state laws and policies. 31 states plus DC allow forced sterilization through laws and court decisions. 17 states have unclear laws, and as of 2022, only 2 states ban forced sterilization. These states are Alaska and North Carolina. A little thing about North Carolina. North Carolina passed their law in 2003 after an investigative series by the Winston-Salem Journal and research by Johanna Schoen. They put a spotlight on North Carolina's history of around 8,000 forced sterilizations. North Carolina ranks 3rd in the country for eugenic forced sterilizations. So now on to policy recommendations. Individual states should ban forced and coerced sterilization with laws modeled after Alaska and North Carolina, which includes exceptions for the physical health of the disabled person. However, determining medical necessity is an ambiguous and often complex decision, and can be misidentified. So laws should include a requirement that 2 doctors must testify that the procedure is medically necessary, not for the purposes of hygiene or convenience. Additionally, a psychiatrist or psychologist should evaluate the disabled individual to understand to what capacity that person can understand the procedure, give consent or assent, and attempt to determine the wishes of that person. It's also essential to keep in mind that sterilization should be available to disabled people who want sterilization. Also, just because a state bans forced sterilization does not mean that people with disabilities under guardianship have the ability to make their own reproductive decisions. Banning forced sterilization is only one step towards reproductive freedom, and if other measures like limiting conservatorships are implemented, there will be fewer reasons to need a law like this, because the laws like Alaska and North Carolina only apply to people under guardianships, which is a problematic concept, which I will talk about next. So my next policy recommendation is to support supported decision-making and limit conservatorships or guardianships. Keep in mind that those can be used interchangeably. So supported decision-making enables disabled individuals to choose trusted advisors to assist them in making decisions, empowering them to retain decision-making power through understanding, considering, and communicating their choices. Also, supported decision-making can help limit conservatorships and guardianships, which can protect people from being forcibly sterilized and give them more reproductive freedom. Okay, here are my references. There's a lot of them. That's not even, thank you. Any questions?
Thank you so much, Sydney, for enlightening us about policies that impact the health of disabled people. You did a really great job. We have lots of time for questions. I see you're getting congratulations. I saw some emojis pop up, and Ayumi is in the chat saying, great presentation. Oh, Ayumi has a question raised. Please go ahead, Ayumi.
Yeah, thank you so much, Sydney, for sharing about this topic and your comprehensive review and research on this topic. I'm wondering, given kind of the landscape of reproductive health policy in the United States, a lot of things are regressing for kind of women with reproductive organs. How does that affect people with disabilities thinking about all these recommendations that you suggested, maybe some thoughts on intersectionality? I would like to hear some thoughts you have.
Well, I think it is just as important for everyone to have reproductive freedom, and some of these restrictions that have been going into place in different states have negative impacts, if not even more negative than on regular non-disabled people. So I think, like, for example, if somebody needed to travel out of state for an abortion and they're a wheelchair user and their wheelchair gets damaged on the flight, things like that. So I think it's even more impacting disabled people than non-disabled people.
Thank you for that. Do we have any more questions for Sydney?
I'll ask one. Just oh, David has one. He can go, and then if there's room, I can ask another one.
Thank you. Thank you for most interesting, thoughtful, and very well presented. I learned a lot. What I was curious about is, does the court have the ultimate authority to make the decision, even if the family or responsible family member who has no signs of any of the issues identified in the previous court decisions, does that family retain the right into majority and beyond age majority? Or does the court ultimately have that authority?
It depends on the state. So sometimes, generally the courts will go with what the family wants, which can be problematic in and of itself, because they could say that they want sterilization even though their person that they have guardianship over doesn't actually want that. And sometimes they'll do it for reasons that would not be considered justified, like hygiene or dealing with somebody's period, because if they don't want to deal with it. I mean, there are some reasons why, but generally the court makes the decision and they go with generally what the family wants. They can even the court can give some very interesting reasons, like whether they think the person's fit to be a parent or whether they're promiscuous or things like that, which I think is a little problematic.
So, thank you very much.
Okay, I can ask. Yeah. So this is my question was somewhat related to David about decision making, but maybe to expand on that is, are there certain It seems like this happens at any age, as soon as reproductive maturity has happened. Is there an age limit? Like, do you see these things happening at all different stages of development, or like, I'm just curious about where some of these cases have come up.
They do. There was one case actually of a she was either 6 or 9, and she had her uterus removed.
Recording in progress.
So she had her uterus removed. She had her breast buds removed to stop her from maturing, which was and that caused a lot of uproar. That was in actually the early 2000s.
Unbelievable.
So if anyone has any questions about supported decision making, it's important to know that decision making is not an all capacity is not an all or nothing phenomenon. And just because somebody needs support to make a decision doesn't disqualify them from participating in the decision making process.
Ah, okay. Thank you. This has been rather eye-opening. So thanks for this presentation.
Okay, any more questions? If not, I'll ask one. Excuse me. Sydney, I know you've done a lot of research on this topic, and you're really an expert in this area because of all of the work that you've done. Can you share a little bit from a public health perspective, what would be the next step? What do we need to have this policy overturned from a data perspective? You highlighted some of the gaps that we have. And so what would be your next step to address this issue?
I think it would be interesting to see if we could get any data on the current status. There's also very little data on conservatorships and guardianships in general. We know that approximately 1.3 million Americans are under those, but we don't know. There's different levels of that. So we need to actually understand that aspect first if we want to create a law that would prevent people under guardianship being sterilized without their consent. So I think we need to know about conservatorships, but we also need to know about how often this is occurring, and I'm not sure whether that data will ever be able to be collected. But I think even one person being sterilized without their consent is too many. So I think there is enough evidence, because there are some case reports that I think could lend evidence into making this something that needs to be addressed. And like I said, the banning the forced sterilization is really only a temporary measure. We need to look at the conservatorship and guardianship laws and do things more like supported decision making whenever possible, rather than giving somebody absolute control over the legal, medical, and financial decisions of another person. Because there actually is partial guardianships, but more often than not, the courts will just approve a full guardianship without actually exploring the least restrictive.
Thank you so much for that, Sydney. We really appreciate that. Please, everyone, join me in thanking Sydney for an amazing presentation. Next, we have Dr. Landon Krantz. He is one of our MHS Master of Health Science students focusing on maternal and child health. He comes to us with a Bachelor of Arts in English from the University of Michigan, Ann Arbor, as well as a Doctor of Medicine degree from the University of Missouri, Columbia. And his presentation is called Nurturing Roots, a process evaluation of Show Me Strong Kids, a grassroots child health initiative that relies on local collaboration.
Thank you. My title also a bit of a mouthful. Let's see if this works. Hold on. Okay. Yeah. All right. So thank you for the introduction, and that was my title. I'll just kind of jump into it for sake of time. So for many of us know this already, but COVID-19 and children. So we know that the infection itself caused less mortality in children than adults, but it did affect children's health in many other ways. Disrupted their education, including their social environment, delays in medical care, especially for kids with chronic conditions, complex disorders, or for like developmental screenings, developmental referrals. They did have to deal with death of family members, parents, and other caregivers and loved ones. And then from a financial perspective, food insecurity, changes in their economic status. So even though there was less mortality, COVID-19 had a huge impact on children across the country. And then the other aspect of this is rural health. So at baseline, even before the pandemic, rural communities suffered from clinician shortages, and there's a whole bunch of reasons why that is. There's also not really well-connected health systems, so a lot of siloing, and people living in rural areas have a shorter life expectancy than their urban counterparts by about 2 years. And then when COVID-19 popped up, a lot of funding went towards clinical care, so to take care of the adults who were suffering in these rural areas, some who were very, very sick, hospital care. And so funding was pulled from population health projects that might benefit children. So with rural disparities, poor child health, and a pandemic, in came a program called Show Me Strong Kids in the state of Missouri. This was funded by the CDC and the Department of Health, and its main goal was to engage community leaders around child health. So to get people from 4 sectors together in rural communities, from the government, from public health, usually health departments, from the schools, and physicians who are seeing patients in healthcare, and get them together to work on some child health projects that work for their community. Not advanced. Oh, okay. Build relationships and connections. So this is a very like basic schematic. So it's more detailed than this, but in a sense, it's the leadership at the bottom builds these groups. It starts with some specialist experts, so experts in asthma, experts in immunization, experts in mental health, and then connects with a local physician, usually in a rural community, sometimes an urban community, and brings these pediatric experts to them to kind of build this grassroots program. And then there's 2 events that are held. One is called Ask Us Anything event, where community members can ask the local physician and ask pediatric experts in leadership any questions they want. And then these roundtable events where they get the local leaders together. And the goal is that you take the knowledge from the Ask Us Anything events, and then you have the roundtable events to create partnerships, to create some ongoing project, something that's child health focused and starts at the local level. So my job in all this was to evaluate its implementation. So we measured 4 process outcomes: the fidelity, did they do the activities as they intended to do? How did they go about recruiting? Were those ongoing projects in existence? Is it still maintenance? And then any contextual factors. And the goal here was to support replication in other states or expansion. And I'm not going to go over this whole slide, but this was kind of a chart of how we evaluated all those outcomes. We did quantitative analysis and qualitative analysis, those mixed methods. One thing I wanted to point out, and I'll come back to later, is one of our fidelity measures was, how many of the sites for this program were actually in communities with significant health disparities. So a big goal of the project was to target rural communities with health disparities. And so we created a health needs index. We ranked all 115 counties in Missouri from lowest need to highest need. And we were hoping that most of the communities that were selected would be in the highest need quartile. So here are our quantitative results. There were 8 sites. So there were 8 counties across Missouri that had a Show Me Strong Kids project. 5 out of 8 were rural, which was not bad, actually. Our goal was 6, so it's pretty good. Every single site had an Ask Us Anything event and a roundtable. Every single site had all 4 sectors recruited, so we got everyone to the table that they wanted to. Only about half of the sites had a formal maintenance project. And then of the health needs index, actually only 1 site, site 5, was in the highest needs, which is the 4th quartile. That would be the worst. And then actually had 2 sites in the lowest needs. So counties that actually have really good health outcomes for children. So overall, fidelity was mixed. There was good fidelity in the activities, but not so much in the health needs area. And then for our qualitative results, we found 5 themes related to success. And for sake of time, I'm only going to be able to go through the first 2. First was availability, and I thought this was a great quote from one of the leaders of Show Me Strong Kids. She said that these sites are a bit of a desert. We're going to rural places. So not only a food desert or economic desert, but a healthcare access desert. It was difficult to find providers that were both physically there and able to dedicate time to be our champion. So these grassroots population health projects take time. And when you're the only pediatrician for thousands of kids, you're in clinic 5 days a week, and you don't, even if you want to, you don't have time to dedicate to this. And then there are counties where there's no pediatricians to be a champion for this project. So how do you can't build a project if the champion isn't available. Another theme for success was engagement. So the physician champions who were kind of at the center of that diagram, the leader said, we couldn't do anything unless we had an engaged physician. Or recruiting champions went through our network of advocacy. So people who were engaged and would actually care about the work. And it ended up being that this balance of needing an engaged team and a rural site with health disparities is why the fidelity wasn't so good on finding areas of greatest need. They found that it was really important not just to have an area of need, but to have an engaged champion. And so you couldn't just go somewhere and make someone do something in another sense. So that balance of needing engaged team members and areas of need kind of affected the fidelity of doing all areas of need. And then the local leaders needed to be engaged. So these projects couldn't be done alone by the physician champion. So one of our champions in their qualitative, in their quote in the Key Informed interview said, when they got to the round table, they would look around the round table and ask myself, who's going to make a change? Who has the power or the drive or the support behind them to make a change? And so some of these roundtable events would have 5 people, some had up to 12, 15 people. And the champions really commented on how they were just trying to really listen to that 1 or 2 who wanted to keep this moving. And it took that teamwork between them and the local leader to create an ongoing project. So when going back to the quantitative results, the 4th column there, the maintenance project. So there was only 4 out of 8. And the key informant interviews identified that really a lot of those sites that lacked an ongoing project was because there just wasn't engagement from either the champion or the leaders to keep something moving. And then I wanted to talk more about the health needs index and the fidelity being low. I already mentioned that part of it was that they needed to balance the engagement. But when you look at 2 of these sites as an example, so Adair County, that circle at the top, that is a very positive health outcomes in that county. They don't have a lot of health needs. They're actually one of the top counties in the whole state when it comes to health outcomes for kids. But what the team did is they picked this because they had an available and engaged physician in that county who really cared about public health, and they're surrounded by quartiles that are lower. So they're surrounded by Knox and Putnam and Sullivan and Lynn, which are really high needs counties. And so they marketed to try to draw from other counties outside. And then I also wanted to point out St. Louis County, which is technically in the 3rd quartile, but it's really driven by the fact that there are just a ton of doctors in St. Louis because of their academic institutions and their hospitals. And St. Louis was actually much lower in other indicators for our health needs index. So even though it looks like it's in the 3rd quartile, there's a lot of high need there. And so the data is not perfect, is I guess my conclusion. And they did the best they could by getting people who are engaged, available, and would do something long term. So overall, my lessons learned from this process evaluation is that if you're going to do a grassroots initiative in a setting with low resources, you're going to need to be flexible. You might need to find settings that are proximal, have close proximity to low resource settings, but aren't low resource themselves, such as Adair County was at the top. And then you have to balance your priorities between your perfect setting and your perfect team. And so, having someone engaged, available, and trusted, and who can build trusting relationships with people in their community, the key informant interviews identified this as equally important, if not more important, than finding an area with high health disparities. Because even the highest need areas, you're not going to have a successful project like this if you don't have a team that's going to see it to the end. And then also that an interesting question that came up is there's a lot of data about rural physician shortages are associated with poor patient outcomes, and there's a lot of drive to recruit physicians to rural areas. And I raised the question if that impact also exists on population health projects, if population health projects have lower fidelity or either poorer outcomes in areas where there are shortages of health department staff, shortages of physicians, shortages of government staff who can make things happen. And so I just wanted to acknowledge the people who helped me make this happen. My family, of course, they got the picture acknowledgement, but everyone else on that list helped me put this project together and helped me through this master's program that I'm very thankful for. And here are my sources, and happy to answer any questions.
Thank you so much, Landon. That was a really fantastic presentation. We'll take questions at this point. Let's start with one. It sounds like the maintenance projects were participatory in nature, right? The communities and the leaders helped create them. Can you give us an example of a maintenance project that was established?
Yeah, and I'd love to have time to get into it because that was actually a really important piece. So the way the projects worked is after the roundtable, they would decide these are the issues facing our community the most, and actually identified a lot of areas of siloing or duplicative work. And then there was actually grant funding from the Show Me Strong Kids program that the community could apply for, and all 4 communities that applied got the funding. And so one example is, you know, a pediatrician who was leading it as a champion was talking about, you know, kids with developmental delays and trying to get them into clinics. And then there was a school representative that said, we actually have a program at an after-school program where kids are able to come in and get therapies and do different learning opportunities. And we have a ton of availability and no one's using it. And so now the pediatrician has a direct referral source and is able to kind of build on that. And then the same way going backwards, they've created a whole open communication where any kids where the diagnosis is uncertain or the treatment plan is uncertain, it's created almost a partnership between the health system where the pediatrician works and the school system to link, you know, communication back and forth about these kids. So they get referred, but then also their treatment plan is coordinated instead of, you know, piecemeal. There was a food pantry that has a bunch of food go to waste, and they found out that it's because people don't know how to cook all these fresh foods or don't have time. So the funding for the new program was to create cooking classes. And if you show up to the cooking class, you get a whole free set of new cookware and food. And this, like, the food pantry was just wasting resources. And so, and the pediatrician's purpose was to improve nutrition and decrease obesity rates. So they partnered together to get grant funding for a dietitian to teach the classes and to have cookware. So you learn how to cook and then you take the cookware home and then you go to the food bank and you actually will use the food instead of it going to waste. And so I also like to say, sorry, I'll say it because I got into this in a couple of years. Each community found its own project. So it was really important for the leadership to not push a project onto a community. You have to address asthma. Your obesity rates are terrible. You've got to address that. It was really the goal of the event were to have the communities decide what matters to them.
I love that. Any other questions for Landon? Dr. Page? Okay. Well,
If you don't go,
fantastic.
I'll ask
Oh.
Landon. Landon, first of all, great job. I'm not surprised. It was wonderful. But tell us what's going to happen with your findings? What are you planning to do with them? What's the next step with this?
Yeah, undetermined. I'd like to publish the findings for anyone who wants to do similar projects to make sure they focus on, you know, not just finding the highest needs area, but finding an area that's set up for success and with the qualitative side to it. And then also share it with the leadership of Show Me Strong Kids, because I believe they are hoping to expand it from 8 sites to 16 sites. And kind of, I didn't go into this as much in the presentation, but there were areas that were not successful, and to kind of highlight those so that, you know, they can be prepared for their next round.
Great.
Okay, so next up, we have Dr. Sharmada Subramanian. She is also one of our Master of Health Science students focusing on maternal and child health. She comes to us with a Bachelor of Medicine and a Bachelor of Surgery in Medicine from Sri Ramachandran Institute of Higher Education and Research. And her title for today is Sudden Infant Death Syndrome and Maternal Drug Use, a Scoping Review.
So good afternoon. My name is Sharmada, and I'm here to present SIDS and maternal substance use, a scoping review today. Just briefly on why I picked this topic. I'm originally from India. I trained in India and did my medicine over there and moved here for residency. I'm a pediatric neurology resident at Arkansas Children's Hospital right now. So the biggest difference I found after moving here in clinical practice was there's a lot of emphasis on safe sleep, and there are a lot of SIDS related cases here, which I did not see back in my practice in India. And I also spoke to a lot of colleagues, and they agreed with me. So I was curious as to why that happens. And I did look through a couple of articles and came across a WHO article that spoke about maternal smoking and why, and that could be a cause of increased SIDS rates in European countries and developed countries versus in Asia. So what is SIDS? SIDS is sudden infant death syndrome. It is the sudden death of an infant less than 1 year of age that cannot be explained by a thorough investigation, including a complete autopsy, examination of the death scene, and review of clinical history. It falls under an umbrella term SUDI, sudden unexpected death in infancy, and it remains a diagnosis of exclusion. When we look at the SIDS rates per country, we see that it is more common in developed countries, with New Zealand having the highest rates, followed by United States, UK, Japan, and the Netherlands. In the United States, SIDS remains one of the leading causes of infant death, according to the CDC. And after the Back to Sleep campaign in 1994, SIDS rates did drop by 60%. And we continue to see racial disparities in SIDS rates. They're seen more in the African American and American Indian communities. And across all races and ethnicities, boys have a higher rate of SIDS. Looking at the risk factors for SIDS, the modifiable risk factors definitely include sleep position, sleep surface. We always make sure to tell our parents to put their babies on their back and not, put a lot of stuffy pillows and blankets around them to prevent overheating. And smoking, of course, is one of the biggest reasons. Irregular medical care during pregnancy, formula feeding, and not vaccinating infants. Non-modifiable risk factors include gestational age, birth weight, and across all categories, babies within 0 to 4 months of life are at higher risk for SIDS. Recent illnesses, race, ethnicity, like I had mentioned, and lower socioeconomic classes. On the maternal substance use path, sorry, my slide is not cooperating to me. Okay. So the impact of substance use on infant development. So these are the most common substances that are used, and most of them have cognitive, physical, behavioral impairments and neurodevelopmental impacts on children. When we look at tobacco, the IUGR and SIDS are the highest impact. Alcohol can cause fetal alcohol syndrome. Opioids can cause neonatal abstinence. Cocaine also causes growth restriction. Marijuana is still under study, but is known to be expressed in breast milk and can cause long-term neurodevelopmental disabilities. So this study focuses on maternal substance use and its relationship to SIDS. I conducted this study from January to July this year and reviewed empirical studies and literature reviews of empirical studies involving infants who were prenatally exposed to substances and mothers with prenatal substance use disorder. It adds to a growing body of literature demonstrating the deleterious effects of substance use in pregnancy, and identifies whether there is a relationship between SIDS and maternal substance use, and presents a discussion on the individual and public health level interventions that can be made. I excluded studies that were not focusing on substance use related SIDS, studies performed outside the US, editorials, opinion pieces, and those that did not report empirical data. So results-wise, there is a strong association between maternal substance use and SIDS risk. The evidence just varies for each drug based on the data availability and the amount of research that's been done. When it comes to smoking, there is a definite risk that is consistently shown across all studies. Similarly, for maternal alcohol use, there is a strong correlation and negative perinatal outcomes. Maternal marijuana use has shown potential positive association, but there is still a lack of data and requires further research. Cocaine and opioid are known risk factors for SIDS. They do have a positive association, but they don't have direct causation mechanisms for SIDS. They're indirect causation factors for SIDS. Limitations of this study, most of the empirical data and the studies that were reviewed, the moms had polysubstance use, so they were using more than one substance. It is obviously subjected to recall bias because most of the habits are self-reporting. Another interesting thing for marijuana in specific is that its potency has increased over the past few years. The marijuana that is used today is not similar to what was used a couple of years ago. So that is something that should be considered in future studies as well. So moving on to preventative measures on an individual scale, the ACOG recommends conducting universal screenings during the first prenatal visit. SBIRT, or screening brief intervention and referral treatment, is what we use. The most commonly used questionnaires are the 4Ps Plus, NIDA, and CRAFT. It's always important to maintain a non-judgmental approach when we talk to our patients and make sure that we're telling them that the purpose of screening is for treatment, not to punish or prosecute. Patients should also be made aware that a potential consequence of a positive screen includes mandatory reporting, but not necessarily prosecution. Discouraging all kinds of prenatal drug use, even if we don't have data on certain drugs and SIDS related, concrete data, we still have to err on the side of caution and discourage prenatal drug use and always follow up postpartum. At a public health level, identifying gaps is the first step. Addressing underserved populations and gaps in current behavioral health systems. Certain populations, underserved populations, are more likely to have higher SIDS rates, so identifying that and working with those communities is important. Workforce development, investing in capacity building, improving care coordination, strengthening the perinatal workforce. There is a critically low, there's a low perinatal workforce right now. So just focusing on that and building that is important. Integrating our health services, combining perinatal and behavioral healthcare services, and removing barriers to healthcare access. Believe it or not, transportation is one of the major barriers to healthcare access for a lot of women. So using telehealth for the same SBIRT screens and outpatient obstetric settings is important. An example of this is the Moms Do Care program in Massachusetts, which has multidisciplinary medical and behavioral health teams for pregnant and substance use disorder individuals. Policy-wise, moving away from punitive approaches, criminalizing pregnant parenting individuals with SUD is very important. These policies are more likely to impact Black and Brown communities. So we need to keep that in mind. And most studies have shown that there's a negative association between these punitive policies and actually bringing women to admit themselves and get treatment. So focusing on the future, we need more research on polysubstance use. I think that's where we're headed because a lot of women who do have substance use disorder are using more than one substance, and there's very limited research on how to tackle that. So focusing on polysubstance use during prenatal and postpartum periods and future research is very important. Conclusion, a multi-level policy approach that engages all sectors of health and social service system and which addresses various aspects of the continuum of care, including prevention of misuse initiation, is warranted. Thank you. I'd like to thank my reader and my mentor, Dr. Sharwan. She's been so kind with my limited time during residency. It's been a huge, it's been a challenge to get this whole thing together, sometimes just physically challenging to do it. And she's been a great support and she's always been there. So I thank her and my family.
Really great job, Sharmada. Thank you so much for, excuse me, thank you so much for that comprehensive review of a really pressing child health issue and maternal child health issue. We'll now open it up for questions. Sydney?
Lovely presentation. It was really informative. I was wondering if you knew, I think the ACOG guidelines are for like opioid stuff is to actually discourage people from going cold turkey, like immediately, just like getting rid of like stopping because of the risks of relapse and overdose. So I was wondering if you could talk a little bit more about that.
Yeah, so it's important that when we approach a patient, that we need to keep in mind that they've been dealing with this substance use for a while, and just making them stop cold turkey is definitely going to lead to withdrawal symptoms, and that is going to make them just go right back to where they started. So basically, keeping that in mind, we need to work with them, and the progress is slow, but it's important to approach it with an open mindset.
Thank you for that. Do we have any other questions? I think one of the great things about all three presentations was the focus on policy. And Sharmada, you mentioned taking a multi-level policy approach, and also that there's really not direct evidence linking marijuana use or cannabis use with SIDS. Can you talk a little bit about maybe how the increase in cannabis dispensaries might have an impact on SIDS, and what we might do to approach this issue as public health professionals?
Yes, I think this is very important because on at one end we are legalizing marijuana recreationally. I understand medically it has its own effects, but we're doing that on one side, increasing recreational, legalizing its use. On the other end, we are prosecuting moms for drug use. So we need to find a balance. And I think the marijuana that we use, that was being used in the past, is not the same that is available today. The potency has increased, and some studies have shown that the amount of carcinogens and toxins in the marijuana available today is almost the same as that in tobacco smoke. So we still don't know what kind of impact it can create on developing infants and moms long term. So I feel like focusing on research and trying to understand those implications first before legalizing recreational drug use is important. Yeah, I think I would start with that step first. Without enough research, I don't think we should be legalizing. And the other thing is, we've been it's very difficult to give anticipatory guidance in clinics when you don't have enough data in your hand. So it's difficult for physicians to talk about, hey, don't do this without enough data in our hands. So I think that's where the research comes in. It's important.
Thank you. Do we have any other questions? All right. Well, that concludes our master's presentations for this section. I thank you so much for all of you for joining us, and congratulations to Sydney, Landon, and Sharmada.